So I've been asked to address intervention in coronary artery disease in 2015. Are syntax change practice in Europe, and if not, why not? And I think Professor Sabik will address the same question for the US. So we may have the same slides, I guess, at least for the syntax trial itself. So I will mainly place my talk in perspective of what we do recommend in the guidelines. Recently, we published last year the 2014 ESC-EACTS guidelines on myocardial revascularization, and I think it's important to emphasize that it's a joint guidelines between the ESC and EACTS, between the two major societies addressing coronary artery disease in Europe. And I think that as far as it is possible, when you have joint guidelines like that, it is much less biased as having cardiological or cardiac surgical guidelines. So having said that, 2014 happened to be the 50-year anniversary of myocardial revascularization. And on this slide, you can see the first coronary artery bypass grafting performed in 1964. And then along the line, the numerous techniques that were introduced to treat CAD besides medical therapy, so coronary angioplasty by Grünsig in 77, the introduction of bare metal stent in 86, and then first and second generation drug-eluting stent. As you can see, looking at the number of trials and the number of patients included in the trial, coronary artery disease has been actually the subject of a huge number of trials, and I think this is one of the diseases that has been studied the most in terms of trials, comparing revascularization with medical treatment or different angioplastic technique against CABG. So our guidelines do address all spectrum of coronary artery disease, from score and risk stratification to process for decision making and patient information, revascularization according to the clinical presentation of the disease, stable CAD, non-STEMI, STEMI, and patient with multiple type of associated conditions such as diabetes, heart failure, chronic kidney disease, or associated other type of disease. Now, what I will do here is to emphasize on important aspects that relate to the syntax score, to show that I believe that the syntax score is having an impact on coronary artery disease treatment, at least to some extent. So what's new in these guidelines? There are actually a lot of things if we compare it to the 2010 guidelines, which was already a combined ESC-EACTS guidelines. Well, first is regarding score and risk stratification, where we emphasize the importance of the syntax score, and we do actually provide a guide to calculate it. There is also a new aspect regarding process for decision-making and patient information regarding timing of intervention, but that does not relate to the syntax score. Basically, what we're saying is that patient with, let's say, advanced lesion that is left main proximal LAD or three-vessel disease and decreased left ventricular function should have revascularization within 2 weeks and within 6 weeks for all other patients. 3, and most importantly, in the chapter addressing revascularization in stable CAD and also in another one, patient with diabetes, there is a long discussion and a very important recommendation regarding the type of revascularization and new generation drug-eluting stent, and there, as you have already seen from Professor Takkar's presentation, the syntax score plays a very important role. Now first, score and risk stratification. So what we did in these guidelines is to make a difference between risk model that can assess and possibly predict short-term outcomes versus medium and long-term outcome. Regarding short-term outcome that is up to 30 days, well, the syntax score does not have an impact there, obviously. It has an impact later on. What we can briefly summarize here is that for CABG, the STS score is probably the best score. It is well validated. About 95% of patients with having CABG are included, even if it's on a voluntary basis in the US. Well, it does undergo periodic adjustments, making sometimes longitudinal comparison difficult. A major difference between the previous guidelines is regarding the Euro score. We are quite ahead, I would say, on current practice, because we do give a class 3 recommendation for Euroscore because it's outdated and it does overestimate mortality, and we give a 2A or 2B, depending upon CABG or PCI, so should be considered or may be considered for Euroscore 2 because it has been validated in a more contemporary cohort. Now, if we look at models assessing medium and long-term outcomes there, the syntax score is important. The syntax score comes from the syntax study, so I think that this is a first significant impact. Now, I think we should make a difference between the syntax score, the original syntax score, which encompasses 11 anatomical variables, 3 general and 8 per lesion, and so it creates anatomical complexity in patients with 3-vessel disease or left main. It was not originally validated for patients with 1 or 2-vessel disease, and it does facilitate treatment selection between PCI and CABG in patients with complex multivessel disease. Second is the interest of the syntax 2, because in addition to 12 anatomical variables, we have 6 clinical variables. So it may become the preferred score for treatment selection between PCI and CABG. So I think this is a first very precise impact of syntax. It is on risk model. The assert CABG and assert PCI are assume both a class 2A recommendation. Now, as I said, again, to emphasize the importance of syntax score, we do provide in the guidelines a guide to calculate the score. Again, it was developed to grade anatomical complexity of coronary lesions in patients with 3-vessel and left main disease, and was found to be an independent predictor of MACE in patients undergoing PCI but not CABG. Now, interestingly, when I give this presentation and ask how many people, even in the cardiological community, use the syntax score, well, a lot of people say, well, I don't. I look at the angiogram and sometimes I make an estimate. Well, obviously, if that's very complex lesion and it's 50 or 52, it doesn't make a difference. But you will see that between, for example, 22 and 25, there is a significant difference in our recommendation. Second, patient having stable CAD, I will not address the aspect of STEMI or antithrombotic therapy because it has nothing to do with a syntax score. So what we did also in parallel of the development of the writing of our guidelines was a network meta-analysis. So all the authors of the guidelines are co-author of this paper, in addition to some colleagues from Bern. And this study was published late June last year in the British Medical Journal. It's a network meta-analysis comparing any type of revascularization versus medical treatment in patients with stable CAD. Now, network meta-analysis has advantages and disadvantages. It's a lot of statistical discussion there. You can see here all the comparisons that were made. The size, so 100 randomized controlled trials were included. It is more than 93,500 patients randomized and a very long follow-up of 262,090 patient years. The size of the circle gives you, is actually in relation with the number of patients randomized. The larger, for example, for bare metal stent or a everolimus-eluting stent, the highest number of patients randomized, and the width of the line gives you is according to the number of trials. So you can see, for example, that sirolimus-eluting stent and everolimus-eluting stent had a lot of trials to compare them. Now, the primary endpoint was all-cause mortality. And as you can see very clearly in this network meta-analysis, CABG decreases significantly by 20% mortality. While on the other hand, early PCI technique, TCA and bimetal stent, and also early generation drug-eluting stent did not impact mortality or survival. Interestingly enough, also, you can see from the bottom part of the slide that new generation drug-eluting stents, so tacrolimus or everolimus, very likely have an impact on survival with a decrease. It's just 3 statistical significance. We should point out, however, the large confidence interval, much larger than for CABG, as you can see, but I think that's good news for second generation drug-eluting stent. Now, having said that, and as it was emphasized in the last presentation and in our discussion, depending on its symptomatic, functional, and anatomical complexity, stable CAD can be treated with optimal medical treatment only or combined with revascularization using PCI or CABG. So there are 2 different questions that we should address. The first is the appropriateness of revascularization, or is optimal medical treatment sufficient? And the second, if we go ahead for revascularization, the relative merits of PCI or CABG in different patterns of CAD. Now, if we go ahead for revascularization, why do we do it? Is it for prognosis, to improve the survival of the patient, which will be the case in certain anatomical patterns of CAD or end a significant ischemic territory? And the second question is, or the second indication could be symptoms. If a patient has only a lesion on, for example, a large marginal artery, and he goes for a stent, that will not improve his survival, but it will improve the quality of life and treating symptoms. And obviously, revascularization and medical therapy are complementary treatment strategies. So regarding the first question, and very briefly, we are fully in line with what has been said by the previous speaker. We need to demonstrate ischemia. And this study published by Ashamovich in 2011 in the European Heart Journal, being an update with a larger cohort of patients as compared to his previous study in the early 2000s, clearly show that the 2 lines do cross each other, do intersect at about an amount of ischemic myocardium of 12%. Below 12%, OMT does better. Above 12%, early revascularization does better in terms of survival. So all our recommendations, or most our recommendations, are based on the demonstration of ischemia, either by pre-angiography testing, using stress test or exercise, or measuring FFR, or both during angiography. Having said that, let's come to the third part, PCI versus CABG. And there we will see the impact of the syntax trial again. So we obviously pooled or looked at all randomized controlled trial comparing PCI versus surgical revascularization, starting from 93, comparing with balloon angioplasty, then bare metal stent, then drug-eluting stent, and you have there at the bottom part of the slide the syntax trial. 1,800 patients were randomized between PCI with paclitaxel eluting stent and CABG, in addition, obviously, to patients being versed into either registry. Now, the 5-year outcomes of the syntax trial, which is in terms of MACE, so the combined endpoint of death, MI, stroke, or repeat target vessel revascularization, is clearly in favor of CABG overall, with an absolute risk difference of about 10%, or a little more than 10%. That was already difference for the primary endpoint, which was 1 year. Now, if we go into the tiles, you can see that there is no difference for patients with a low score, but there is a difference for patients with an intermediate score, 23 to 32, and for patients with a high score, that is 33 or above. If we dig a little bit into 3-vessel disease and left main disease, we have interesting observation, but please bear in mind first, then the primary hypothesis was non-inferiority of paclitaxel-eluting stent at 1 year for MACE. This hypothesis was not met, as there was inferiority, so all subsequent analyses are hypothesis generating only. And that, I think, should be important from a statistical point of view to be kept in mind. So if we look at the 3-vessel disease subset, there is a 13% difference. That's even higher or larger when you remove patient with left main disease, and you can see that this difference starts before 1 year up to 5 years. Now, if we divide patient with 3-vessel disease according to the syntax score, there is no difference in MACE for patient with 3-vessel disease and a low syntax score, at least no statistical difference. There is, as you can see at the bottom part of the slide, a difference just significant for repeat target vessel revascularization. If we move to patient with intermediate score, there is a difference. This is highly significant, 22 versus 38%. And if we look at patient with high syntax score, that is even higher, 24 versus 42%. And as you can see, if we divide the different components of the endpoint, it is significant for death, for MI, or for repeat target vessel revascularization, not for stroke. Now, if we look at left main disease, we had a lot of evidence, the syntax, I will come to that in a minute. We also had this 2011 meta-analysis published in JACC by Capodano and al., where you can see it does include Le Mans, syntax, and pre-combat. The 5-year results of pre-combat was just presented last week at the ACC meeting in San Diego. There is no difference between PCI and CABG in this meta-analysis. What about the syntax score? If we look, the syntax trial, if we look at patient with left main disease, you can see that for patient with low score or intermediate score, there is no difference. And for patient with high score, there is a difference of about 16%. It's about the same statistical difference of absolute risk reduction or absolute risk increase, depending upon you consider CABG or PCI, as for patient with 3-vessel disease and a high score, which is logical, because to reach a score, you need multi-vessel disease, actually. Now, interestingly, if you divide that into the different aspects of left main disease, you can see here this is not statistically different when you look at all patients with left main. Now, interestingly, there is a very large heterogeneity of left main disease in the syntax trial. Look at patient having left main only, 1-vessel disease, 2-vessel disease, and 3-vessel disease in addition to left main. And you can see that for patient with left main only, PCI does better. It is not statistically different, but the number of patients is quite small, 97 or 91. But if you increase the complexity of the disease and go to patient with 2 or 3-vessel disease in association with left main, then CABG does better. And again, if you divide by syntax score, no difference for low score, no difference for intermediate score, and significant difference for high score. For the combined endpoint, interestingly, no statistical difference for death, MI, or stroke. Now we come to this table of recommendation that Professor Taggart has already commented. I would first like to point out to the title of the recommendation. That's very important. Recommendations for the type of revascularization, CABG or PCI, in patient with stable CAD, with suitable coronary anatomy for both procedures and low predicted surgical mortality. So those are patients for which, for example, associated comorbidities are not too high. We're not talking about the 85-year-old lady with COPD and some creatinine level increase, obviously. That's a different story. Now, what we can emphasize here is that patient with 1-vessel disease and proximal LAD, as for both CABG and PCI assume a class 1. It's an upgrade of PCI, which was a 2A in the previous guidelines. So it's the same level of the same class of recommendation. For patients with left main disease and a low syntax score, CABG and PCI assume the same level of recommendation. And for patients with three vessel disease and a low syntax score, also the same level of recommendation. On the other hand, for patients with left main disease and a high syntax score, or three vessel disease and a high syntax score, CABG assume a class 1 and PCI assume a class 3. So what should we do when we have patients for which both recommendations can be the same? Well, I think then we come to decision making and patient information. I think that these patients should be discussed within the heart team very clearly. And if the patient has very complex mortality, then they should be discussed within an expanded heart team that can include other specialists. So we very clearly in the guidelines emphasize the importance of informing the patient about benefit and risk ahead of the diagnostic procedure, and also to develop heart team. So I think a drawing like that is shown to the patient can very well be explained to show the difference between stenting and coronary artery bypass grafting. So to conclude, I think that the guidelines emphasize the importance of the calculation of the syntax score, and the syntax score can be used to direct patient, or at least have a discussion between CABG and PCI. So CABG remains the standard of care for patients with three vessel disease. Mortality is lower. CABG results are independent of complexity in coronary anatomy. Left main disease, the Excel study needs to confirm the results, but I think that PCI has a nice future for patients with isolated left main disease. And I also think that reimbursement should be based on following practice guidelines. So to answer the question, as CABG changed practice in Europe, I think it has partly changed practice, but likely not enough. Thank you for your